Good morning, students. Today we will see the solved question paper of January 2022 of 2010 scheme. So the first essay is Mrs. Rima, 28-year-old primary gravida at 38 week of gestation, got admitted in an antenatal ward with increased blood pressure and decreased urine output. Define preeclampsia and enlist the risk factors of preeclampsia and describe the management of preeclampsia. The definition of preeclampsia, it says, preeclampsia is a multi-system disorder of unknown etiology characterized by development of hypertension to the extent of 140 by 90 millimeter of mercury or more with proteinuria after 20th week in a previously normotensive and non-proteinuric patient. The risk factors of preeclampsia, especially it occurs in the first pregnancy and the patient who got pregnant before younger the age of 18 or older than 35, prior history of preeclampsia, black race. Medical risk factors for preeclampsia include chronic hypertension, renal disease, diabetes, antiphospholipid syndrome, twins, and family history of preeclampsia, especially in the mother or the sister, placental abnormality, genetic causes, and RH incompatibility, obesity, maternal infections, diet inadequate of nutrients, especially protein, calcium, magnesium, vitamin E and C. The management of the preeclampsia, if it is a severe preeclampsia at 38 week of pregnancy, so it is almost that the patient, the fetus will be got mature. So the fetal lung maturity might be acquired. So in those cases, admit to the labor room, maternal and fetal assessment, consider for magnesium sulfate to prevent eclampsia, treat dangerous hypertension. And if the patient is if the patient is the hypertension is manageable or it comes down, then we can wait for the normal delivery to occur. Or if it is absent, it is considered to have a cesarean section. Then define normal labor, explain the physiological changes takes place in the first stage of labor and management of a woman during first stage of labor. WHO in 1997 defines normal labor as spontaneous in onset, low risk at start of the labor and remaining throughout the labor and delivery. The infant is born spontaneously in the vertex position between 37 to 42 weeks of completed weeks of pregnancy. After birth, mother and infant are in good condition. First stage is the beginning of the true labor pain till the full dilatation of cervix. The physiological process in the first stage is divided into two. The first one is uterine actions and second one is mechanical factors. Under uterine action, the first one is fundal dominance. The contractions begins at the fundus, then spread across downwards the body of uterus. It is maximum intensity at the fundus. This is known as the fundal dominance. Second is polarity. Polarity is the neuromuscular harmony between upper and lower pole of the uterus. Upper pole contracts and stronger and retract to expel the fetus and the lower pole contracts slightly and dilate to allow the expulsion to occur. Contraction, retraction. Uterine contractions are involuntary. They are controlled by nervous system and endocrine influence of the woman's body. During labor, the contraction does not pass off completely. After the contraction, it retains some amount of contraction, and this property of uterine muscle is known as retraction. Formation of upper and lower uterine segment. Upper uterine segment is more muscular, mainly deals with contraction, and lower is thinner and distant and for the dilatation. Retraction ring. A ridge between upper and lower uterine segment, normally not visible over the abdomen, but during the obstetrical labor, it is prominent over the abdomen and it is called Bandel's ring. Cervical effacement. The term refers to the merging of cervical canal into the lower uterine segment, leaving external os as thin-edged circular orifice. Cervical dilatation. The process of enlargement of cervical os from few millimeters to opening large enough to pass the baby. Then eighth one is ripening of cervix, the process by which cervix becomes soft, complete, and partially dilated in terms of cervical ripening. Then the second fact is mechanical factors. The formation of forewaters. The lower uterine segment stretches as a result of strong action of uterine muscle. Second, general fluid pressure. During the uterine contraction, there is a lot of pressure on the fetus, the membrane, the placenta, umbilical cord, and amniotic fluid. Rupture of membrane. The ideal time for the rupture of membrane is the end of the first stage of labor. Once the cervix is fully dilated, it gives no support To the forewaters, artificial rupture of membrane can be carried out using surgical forceps. The fourth one is fetal access pressure. It is the exertion of force on the cervical canal of the mother during contraction and retraction. Then, the short notes, management of puerperal sepsis. In many situations, infection may be so rapid and overwhelming that death is unavoidable. However, early intervention may prevent the situation become irreversible. The urgent and repeated bacteriological specimens, including blood culture, should obtain when the infection develops and the woman is systemically ill. Advice from a microbiologist must be sought early to ensure appropriate antibiotic therapy. Sepsis is treated with intravenous dose of appropriate broad-spectrum antibiotics. When there is a strong clinical suspicion of sepsis, you should commence parenteral broad-spectrum antibiotics immediately without waiting for microbiology result. This should happen even if the presence of diarrhea, thus gastroenteritis as a possible diagnosis. Fluid resuscitation and oxygen therapy are also important as a part of treatment. Serum lactate should be measured within 6 hours if there is a suspicion of severe sepsis in order to guide the management. Serum lactate more than 4 millimole indicate of tissue hypertension, perfusion. Relevant imaging studies should be performed promptly in an attempt to confirm the source of infection. Management of hyperemesis gravidarum. The principles of management include to control vomiting, to correct the fluid and electrolyte balance, to correct metabolic disturbance, to prevent serious complications of severe vomiting, hospitalization. In hospitalization, we have to admit the patient, open IV line and correct fluids, send for relevant investigations including hemoglobin, maintain intake output chart, monitor urine output, monitor the vital signs and test urine periodically for ketone bodies. The fluids, oral feeding should be withheld for at least 24 hours after cessation of vomiting. During this period, fluid given through IV drip. An amount of fluid infused 20 hours calculated as total amount of fluid approximately 3 liters, of which half is 5% dextrose and half is slinker lactate. Extra amount of 5% dextrose equal to the amount of vomiters and the urine 24 hours is to be added. This measures helps to correct dehydration, electrolyte imbalance and ketoacidosis. Enteral nutrition through nasogastric tube may also be given. Before IV fluids is given, oral small frequent dry meals without fat-free are given. First try carbohydrate like biscuit, bread and toast. Ginger is helpful and gradually full diet can be restored. Nursing care, symptomatic but firm handling of the patient, daily monitoring of the patient. Look for signs of improvement in the patient is like subsidence of vomiting, feeling hungry, better look, disappearance of acetone breath from the urine, normal pulse, blood pressure and normal urine output. Monitor lab results for dehydration, monitor fetal heart rate, sound, fetal activity and growth. Encourage patient to sit upright after the meal. Encourage small and frequent meals. Liquid should be taken between meals to avoid distending stomach and triggering vomiting. Physiology of lactation. There are 4 steps. The first one is preparation of the breast, otherwise known as mammogenesis. Pregnancy associated with remarkable growth of both ductal and lobular alveolar system. Second is synthesis and secretion of breast alveoli, that is otherwise known as lactogenesis. Even though some secretory activity is evident during the antepartum period, milk secretion actually starts from the 3rd or 4th postpartum day. In spite of hyperlactin level during pregnancy, the milk secretion is inhibited due to high circulating levels of estrogen and progesterone. Prolactin, insulin, growth hormone and glucocorticoids are the important hormones at this stage. The third is ejection of milk, galactogenesis. Oxytocin is the major galactokinetic hormone. Discharge of milk from mammary gland depends not only suction exerted by the baby during the suckling but also on contractile mechanism which exposes the milk from alveoli into duct. And the fourth step is maintenance of lactation, otherwise known as galactopoiesis. Prolactin appears to be the single most important galactopoietic hormone. For effective and continuous lactation, frequency of suckling is essential. Distension of alveoli by retained milk is due to failure of sucking. This causes decrease in milk secretion by alveolar epithelium. Ductal and alveolar distension due to failure of milk transfer is cause lactation failure. Fetal circulation. The circulation of oxygenated blood, deoxygenated blood, nutritive material, etc. in the fetus is termed as fetal circulation. The blood vessels responsible for the circulations are umbilical vein. It carries oxygenated blood from the placenta to the growing fetus. The blood pressure inside the umbilical vein is approximately 20 mm of mercury. Umbilical artery. It is a paired artery that found in the pelvic and abdominal region of the fetus which extends the umbilical cord, supplies deoxygenated blood from the fetus to the placenta. They surround the urinary bladder and then carry all deoxygenated blood out of the fetus. The three shunts present in the fetus are: one is ductus venosus. Ductus venosus shuns the portion of umbilical vein blood flow directly to the inferior vena cava, allows oxygenated blood from the placenta to bypass the liver. Ductus arteriosus connect the pulmonary artery to the proximal descending aorta. It allows most of the blood from right ventricle bypass the fetus fluid-filled non-functioning lungs. Foramen ovale. It is an opening in the intra-atrial septum. It allows the blood to enter left atrium to the right atrium. Indication of cesarean section. Absolute indications are placenta previa, central placenta previa, contractile pelvis, pelvic mass causing obstruction like broad ligament fibroid, advanced carcinoma of cervix, vaginal obstructions. Relative indications are previous cesarean sections, non-reassuring fetal heart rate, dystocia due to large fetus, small pelvis or insufficient uterine contractions, antepartum hemorrhage, malpresentation, failed surgical induction, bad obstetric history, hypertensive disorders, medical or gynecological diseases complicating pregnancy on maternal request. Magnesium sulfate is a drug of choice for eclampsia. It acts as a membrane stabilizer and neuroprotector. It reduces the motor and place sensitivity to acetylcholine. Magnesium also blocks neuronal calcium influx. It also induces cerebral vasodilatation, dilates uterine arteries, increases production of endothelial prostacyclin, and inhibits platelet aggregation. Thus, it prevents occurrence of seizure. Stripping of membrane induces the labor. Thought to work by release of endogenous prostaglandin from the membranes and deciduous. Manual exploration of cervix triggers Ferguson reflex, which promote oxytocin release from the maternal pituitary. Inadequate emptying of the breast leads to breast engorgement. Breast engorgement is caused by congestion of fluid and blood in the breast. Fullness in the breast from the early milk production can prevent drainage of fluid and cause painful swelling. Progesterone helps to maintenance of pregnancy. Progesterone is known as pregnancy hormone. Progesterone is key to create a perfect environment for the ovaries to harbor the fetus by keeping the uterus muscle relaxed and helping the immune system to tolerate foreign DNA. Progesterone helps the fertilized egg be implanted in the uterus to establish pregnancy and help maintain a healthy pregnancy. Women ovarian follicles might also be poorly developed and may not secrete enough progesterone on their own. In these circumstances, progesterone will need to supplement it as well. Molding takes place throughout the labor. Alteration in the shape is possible because the bones of the vault allow slight degree of bending and skull bones able to override the sutures. This helps considerable reduction in the size of presenting diameter at right angles to them to be able to lengthen due to the skull bones and helps in the easier delivery. Differentiate between true labor and false labor. In true labor, contractions follow a regular pattern. Contractions come closer together and tend to last longer. Contractions get stronger with ambulation. Contraction seems to start in the lower back, then travel to the lower abdomen. Contractions not stop by controlling breathing or sedation. Cervix softens, effaces and dilates. Fetus continues to descend into the pelvis. But in case of false labor, contractions rarely follow a pattern. They vary in length and intensity. They frequently stop with ambulation of position. Contraction may be felt in the back but often noticed in the fundus. Contractions eventually stop with relaxation intervention. Cervix may be softened but little or no change in effacement or dilatation. No significant change in fetal position. Menorrhagia is a cyclic bleeding at normal intervals. The bleeding is either excessive in amount greater than 80 ml or duration more than 7 days or both. Common causes include dysfunctional uterine bleeding, fibroid uterus, adnenomyosis and chronic tobo ovarian masses. Treatment directed to the underlying pathology. Amenorrhea is the absence of menstrual periods. The most common cause is hormone interruptions, which can lead to the emotional stress, extreme weight loss, excessive exercise, or certain reproductive disorders. The absence of periods can cause an underlying disease. Examples include menopause, pregnancy, use of birth control, medication side effect, delayed puberty, and stress. Quickening and lightening. Lightening is 2 to 3 weeks before the onset of labor. The lower uterine segment expands and allows the fetal head to sink lower. It may engage. The fundus no longer crowds the lungs. Breathing becomes easier. The heart and stomach can function more easily, and women may experience a relief from shortness of breath. Commonly seen in 36 to 38th week of pregnancy in a primary gravida, and for a multigravida it occurs at the onset of labor. But the quickening is the first fetal movement pursued by the mother. It occurs around 18th week for a primary and 2 weeks earlier for a multigravida mother. Difference between abruptio and placenta previa. Both occur in third trimester, but in abruptio placenta, the bleeding may be concealed, external dark, hemorrhage, or bloody amniotic fluid. There is usually pain will be present, irritable uterus, progress to broad-like consistency. Fetal heart rate may be irregular or absent. The presenting part may not be engaged. Moderate to severe depending upon the extent of concealed hemorrhage. But the placenta previa is mostly external, small to profuse in amount, bright in red. Usually the pain is absent and the uterus is soft. And the fetal heart sound will be normal, and usually the presenting part is not engaged, and shock is not present unless bleeding is excessive. Threatened abortion, inevitable abortion. Where the process of abortion has started but not progress from the recovery is impossible. That means the recovery is possible. Those cases known threatened abortion. The treatment include rest, drugs, sedation, pain relief, general measures like asked to preserve the vaginal pad to know how much the bleeding, to report any excessive bleeding. Advice on discharge include limit the activities for 2 weeks. Coitus is contraindicated. But in case inevitable abortion is a type of abortion, the progress into a state from which continuation of pregnancy is impossible. Clinical features include increased vaginal bleeding, increased pain in the lower abdomen, and an internal examination shows dilated os through which the products of conception are felt. Active treatment includes before 12 weeks D&E followed by curettage of uterine activity under general anesthesia. After 12th week, uterine contraction accelerated by the oxytocin trip. If bleeding is profuse with cervix closed, evacuation of uterus by abdominal hysterectomy. Thank you.